All right, well, welcome. This is our first official session of today and of our conference. I'm Stacy Sigmund. I'm a professor in psychiatry and psychology departments here at UVM. And I'll be the chair of this morning's first session. Just some quick housekeeping first to get us all oriented and on the same page. So in terms of the framework for this session, and I imagine the others, we'll have each presenter go, I'll call you up and you can just come up for your talks and then return. And then we'll save any questions and discussion until the end of the three presentations. And then I'll actually have you guys come up and sit at the table. We'll kind of have a panel discussion at that time, okay? But certainly, and then at that time, if you're attending in person, you can come up to one of the microphones to ask questions. And then I think for those attending virtually, you can submit questions, right, Charlie, anytime. And you're in the back steering that bus. You can call them out at the end, questions that get posed in that forum. And then all of our sessions are being recorded and will be posted to the VCBH website after the meeting. And so, as I said, this is our first session one, and we're going to dig into recent advances in contingency management. Our first presentation is by Sarah Heil. Dr. Heil is also a colleague of mine at the University of Vermont. She's a professor of psychiatry and psychology. She's a faculty member of our VCBH Center and the associate director of the UVM Center on Rural Addiction. Dr. Heil's primary research interests include the reproductive health needs of people with substance use disorders, with a recent focus on helping to prevent unintended pregnancies. And so this morning, she's going to be sharing her research investigating contingency management approaches for improving family planning among socioeconomically disadvantaged women. Sarah.
Okay, thank you very much. Yes, I'm going to be talking about improving family planning among women receiving medication for opioid use disorder this morning. A brief outline, I'm going to give you just some background in this area, then talk about a stage 1B trial where we evaluated the efficacy of an intervention that we developed to address this area, followed by a stage 2 trial. So background in terms of sexual and reproductive health among women with opioid use disorders, the American Society of Addiction Medicine advises providers to discuss sexual and reproductive health with their female patients when they're entering treatment for opioid use disorder. And it's really important that we do so within a reproductive justice framework. And this framework calls for supporting each patient's decision about whether and if and when they want to get pregnant, and also assessing each patient's desire for pregnancy in a non-judgmental way, so that we're equally supporting those who want to become pregnant, those who don't want to become pregnant, and those who are somewhere in between. What do we know about desire for pregnancy among women with OUD, especially when they're first entering treatment? There are no nationally representative prospective assessments of desire for pregnancy among women with opioid or other SUDs, to my knowledge, like there are for the general population. We have that data pretty much every single year for the general population. Probably the next best data that we have are pre-screening data from the Mother study. The Mother study screened almost 1,000 pregnant women using opioids across 8 different sites, 6 in the US and 2 international. Again, they're already pregnant, so they were asked about the intention status of that pregnancy. 14% said that they had wanted to be pregnant at that time. 26% weren't sure whether they wanted to be pregnant at that time or not. And then 61% said that they did not want to be pregnant at that time. So suggestive that there was some significant unmet contraceptive need in this population. So first, let me just talk a little bit about prescription contraception. These are the methods that we consider prescription methods because you either have to get a prescription or you have to have it inserted or administered by a provider. So we have pill, patch, ring, the injection, IUD, and implants. IUD and implants are often collectively referred to as long-acting reversible contraceptives, or LARCs. And the reason that they are so effective is because once they are inserted or implanted, you don't have to do anything else. And they also last for many years. So you can be protected for a long time if you want to be. In terms of effectiveness, if you are sexually active, not using any method at all, about half of women will become pregnant over the course of a year. Introducing any sort of contraception, even condoms, reduces that pretty substantially down to around 13%. And then with each move to the right of this arrow, you're cutting it in half over again. So pill, patch, and ring, you're down to about 7%. The contraceptive injection, about 4%. And LARCs, again, the most effective methods, less than 1%. Unfortunately, when we look at the prevalence of use among women who are using opioids and other substances, it goes completely the other direction. So about 50% are not using any method at all. 30% are relying solely on condoms, 10% on the short-acting prescription methods, and then about 10% at best are using LARCs. So it certainly seems like a majority of women who do not want to become pregnant are at serious risk for becoming pregnant. So how do we improve this situation? Historically, there's been really not much scientific effort in this area. The few trials in the literature when we first started this work were primarily motivational interventions that were targeting women who were drinking at risky levels and using ineffective contraception, but very few studies with women who have actual substance use disorders. So that's what got us started in this area. We developed an intervention that was informed by behavioral economics and then tested it first in a small pilot trial. We recruited women who were receiving medication for opioid use disorder and at risk for unintended pregnancy, and assigned them to either usual care or the 6-month experimental intervention. And we did put the first 5 into the experimental condition to just give us some practice with it. Usual care was given just general information about contraceptive options and referrals to local providers. This is very consistent with what ASAM recommends for substance abuse providers. So it's great that they are having their guidelines that this should be addressed, but what they're recommending, honestly, is not a lot. This experimental intervention consisted of 2 components. The first is contraceptive services that are guided by the World Health Organization's decision-making tool, typically at their first visit with us. And that was followed by incentivized follow-up visits for another 13 visits. I'll tell you a little bit more about each of these. So the WHO tool is really focused on initiation of contraception. So recommends things, trying to reduce barriers that keep women from initiating contraception. So for example, you don't have to do a physical exam to provide a woman with a contraceptive method. You should also provide structured educational counseling about whatever method she chooses. In our study, again, we're offering pill, patch, ring, injections, implants, and IUDs. Also, if possible, you should supply the chosen method for free and also offer the option of initiating the method immediately rather than waiting until after her next her next period. So then all of those practices have been shown to increase contraceptive initiation, but then we were very worried about continuation. That we know even in the general population, about 65% of women who start a new prescription method have stopped using it within 6 months. And again, I don't know of any data in women with substance use disorders, but we presumed it would be even worse. So that's where the incentivized follow-up visits come in. We offered monetary incentives contingent solely on attending follow-up visits. It was not on using contraception. So there were 13 of these follow-up visits over 6 months, total potential earnings of $437.50. At each visit, for women who were using a method, we assessed potential side effects, tried to help them manage those side effects, any adherence issues they were having, and offer them the possibility of switching methods as well. So if the first thing they chose, they weren't happy with it, they could always switch to another method as many times as they wanted. And then for women who did not choose a method, they could still come in, they still earn the incentive for coming to the follow-up visit, but there was never an obligation to start or continue a method. And all of this was done at a clinic that was co-located with a OUD treatment clinic, so on-site services. Inclusion criteria, they had to be of reproductive age, they had to be able to get pregnant, so not be premenopausal, have no history of tubal ligation or hysterectomy, be heterosexually active in the past 3 months, have no plans to get pregnant in the next 6 months, be medically eligible to use the methods that we were offering, not be reporting already using those methods, couldn't be facing imminent incarceration, speak English well enough to participate in the study, be at least 6 months postpartum, and also receiving medication for OUD for the past 30 days. Those last two were put into place because of some kind of quirks in our area at the time, but we ended up loosening those two in the stage 2 trial. Here's our consort chart. So we pre-screened 74 women. 49 of those were eligible for in-person screening, of whom 32 were eligible. And they were then assigned to 16 in the experimental condition and 15 in the control condition. And again, the first 5 in the experimental condition were put in consecutively. The main reason that women were ineligible for the study at either stage of screening were because they either didn't have an opioid use disorder or they weren't at risk for an unintended pregnancy. They really didn't need our services. Demographic characteristics, no differences between the 2 conditions. So if you just look in that first overall column, they're about 30 years of age, mostly white, high school education, unemployed, never married, but they do mostly have a steady male sexual partner. Most were on methadone and most were smokers. So very consistent with what we think of as a typical opioid use disorder population. In terms of reproductive and contraceptive history, they first started having sex at about 15 years of age. They've been pregnant about 3 times already. Almost all of them have already had one unintended pregnancy in their lifetime, and all of them have used prescription contraceptives before. Okay, so our first and our primary outcome was self-reported point prevalence prescription contraceptive use. We looked at 3 different time points at 1, 3, and 6 months after trial entry. And in this case, point prevalence meant reporting correct and consistent use in the past 7 days. So when we looked at those 3 different assessment points, the control condition is in the gray bars, the experimental condition is in the black bars, and you can see we have significant differences at each time point with a 4- to 7-fold higher rates of prescription contraceptive use in the experimental versus the control conditions. Also, we did not see any adverse consequences in terms of condom use. It was not the case that by giving them this other kind of contraception that they suddenly stopped using condoms. In fact, 2/3 or more of the women at baseline had not been using condoms when they entered the trial. So something of a floor there. There wasn't a lot for us to potentially make worse. Other outcomes we looked at, we did look at the percent of participants who were using LARCs at the end of the study, those most effective methods. This wasn't significantly different, but again, a more than 5-fold difference here. And the percent who became pregnant during the study, we weren't anywhere, remotely powered to look at this, but you can see it almost achieves statistical significance, and just remarkable that in a 6-month period, 20% of the control condition became pregnant compared to none of the women in the experimental condition. So with these data looking very promising, we proposed a stage 2 trial. We had the same usual care condition as in the 1B trial, also the same 2-component intervention, but then we added a third arm that could allow us to isolate the effect of the incentives. So this middle condition is contraceptive services alone. They got the same contraceptive services guided by the World Health Organization tool, typically at the first visit. We're invited to come in for those same 13 follow-up visits over the next 6 months, but they just didn't receive any incentives for doing so. Also, I'll probably sometimes refer to these groups now as UC or CS or CS plus. I use those terms kind of interchangeably. A couple other differences between this and the 1B trial. We verified adherence this time. So the first trial was self-report. This time we worked on verifying adherence and also over a longer period of time. So for pills, we did pill counts. For ring, we asked if we could do a pelvic exam. Injection, we did medical record reviews. IUD also asked if we could do a pelvic exam. And for implant, you can palpate and feel the implant under the skin. And we did it over a 28-day period instead of 7 days in the 1B trial. We also looked over a longer assessment period. So we added an additional assessment 12 months after the start of the intervention. So the intervention still ended at 6 months, and then we were looking 6 months later to see if there were continuing effects. And then last, we also did a benefit cost analysis. So that started by estimating the cost to raise a child exposed to opioids in utero from age 0 to 18. And this analysis took the societal perspective. If you often see that it will cost benefit analysis will look just at healthcare costs, but this incorporated healthcare costs as well as childcare and education and housing and food and clothing and everything that it would actually take to raise a child. Okay, inclusion criteria, very similar to the 1B trial. I mentioned those last two. We reduced it just, they had to be 8 weeks postpartum and just receiving medication for OUD. It didn't matter how long they'd been in treatment. The consort chart for this trial, we screened 347 women, 142 were eligible, a small handful declined to participate. So we had 138 who underwent randomization, 48 were assigned to usual care, 48 to contraceptive services, and 42 to contraceptive services plus incentives. And again, the main reason that they were not eligible was because they weren't at risk for unintended pregnancy. So we had quite a few that were already reporting using contraceptives, prescription contraceptives, a number who weren't heterosexually active at that point, or they'd actually already had a tubal ligation or a hysterectomy and had permanent contraception. Demographics, again, very similar to what we saw in the 1B trial and no differences between conditions. I will add, at the last two in the table, we did ask about intentions to start prescription birth control in the next week. And almost all of them said, yes, they intended to do so. And also ask whether they preferred a long acting method. So one of those LARCs, IUD or an implant, or did they think they would prefer a short acting method, so pill patching or injection? And about half in all three conditions said that they thought that they would like to have a long acting method. Okay, so first follow-up attendance. Did they actually, come to the visits that we were incentivizing, and how did that look in the two conditions? So on the left, you can see that the contraceptive services group attended only about 30% of the scheduled visits, whereas those in the contraceptive services plus incentives came to 80% of the visits that we scheduled. Our primary outcome, again, in this case, verified use at 6 months. We had a 95% follow-up rate at this assessment with no differences between conditions. We also assumed if they didn't come for the assessment that they were not using contraception. So here we have the proportion with verified use in each condition. It's 10% in the UC, 29% in CS, and 55% in CS plus. Significant differences between all possible combinations, but you can see that very nice graded effect that you might expect given the study design. Secondary outcome, we also looked at that new 12-month assessment 6 months after the intervention was over. Again, 92% follow-up rate, no differences between conditions. And here we've got 6% versus 25% versus 43%. The difference between CS and CS plus, not quite significant this time around, but again, that very clear graded effect. Another secondary outcome we looked at was verified LARC use at both the 6 and 12-month assessments. Here at 6 months, it's 0 versus 23 versus 43. Again, significant differences between all combinations. And at 12 months, 0 versus 21 versus 41. So pretty consistent percentages across the two assessments, which isn't necessarily surprising because, again, these are long-acting methods. So once you get it, if you're happy with it, if you're not having side effects or any issues with it, you're likely to continue with it for a long time. And I also just want to point out, I mentioned in the demographics table that 50% of all the participants thought that they would prefer a long-acting method. And here you can see none of the usual care participants ended up with a long-acting method, and only about half of the contraceptive services. So I think that, illustrates that access to those sorts of methods is difficult. And if you're not making a lot of effort to make them more accessible, this is what you end up with. And then, of course, pregnancy. We looked at unintended pregnancy over 12 months. We had originally asked at intake, what their intentions were for the first 6 months. We asked again at the 6-month assessment what their intentions were for the next 6 months so that we could make sure that we were categorizing any pregnancies that occurred in that second 6-month period appropriately. But here we have 22% in usual care, 17% in contraceptive services, and 5% in contraceptive services plus incentives. Again, we weren't powered for this, and not all the differences are significant, but again, you see the expected graded effect in the opposite direction now. Okay, in the benefit cost analysis, this slide is going to look, deceptively simple. You can't imagine the incredible amount of work that goes into trying to accurately assess all of these costs, but they just then get boiled down to, simple dollar amounts. But so estimating the societal cost of a pregnancy exposed to opioids in utero, we ended up with $85,122. And then looking at the benefit cost ratios, comparing usual care to contraceptive services was $5.59. So every additional dollar that you put into contraceptive services over what you would already pay for usual care, you get $5.59 in savings. Usual care versus contraceptive services plus incentives is $6.14. And then even comparing the two intervention conditions to each other, the additional added incentives gets you another $7 almost. And our health economist says that this is kind of unusual, that typically you see diminishing returns when you add components together like this, that the additional dollars don't typically add up in a proportional manner, but that the similarity in the benefit cost ratios indicate that you are getting additional benefit and it is proportional. So in summary, we saw graded effects of interventions on prescription contraceptive use, with the best effects coming in the condition that was getting the incentives as well. Importantly, this pattern persisted after the intervention period. So, contingency management is so often criticized for the effects going away after the intervention is over. But here's one instance where, again, because so many people, I think, were using long-acting methods, that you get a continuing effect. The graded effect also was apparent in the unintended pregnancy rates, which is obviously ultimately what we were after. And then both interventions were very cost effective compared to the societal cost of an unintended opioid exposed pregnancy. But again, the group that got the incentives had even additional benefit, even though both interventions were effective and cost effective. And then those benefits remain proportional as the cost went up. So future directions, both of these interventions help women who are receiving medications for opioid use disorder who don't currently desire pregnancy reach that goal. And while they are the majority, there are women who do want to become pregnant and some who aren't quite sure what they want to do at this point. So we're starting now to think about what issues women who are receiving MOUD who do want to get pregnant need to address to increase the likelihood of having a healthy pregnancy, and how incentives might fit into those behaviors. So knowing the high prevalence of smoking in this group and the adverse consequences of smoking during pregnancy, and also with opioid exposed pregnancies, increasing the severity of the neonatal abstinence syndrome, I have to imagine that smoking cessation is going to be in the mix there. Taking folic acid, it helps prevent neural tube defects, and there's some data to suggest that women who use opioids are at higher risk for neural tube defects, so that might be an important one as well. Infectious diseases, that's including everything from chickenpox and rubella, where there's vaccinations and immunizations available, but also STIs. You want to take care of those ideally before you become pregnant. So these are some of the issues that we're looking into and trying to figure out how to incorporate them and how incentives might fit there. So I want to acknowledge funding from NIDA and from NIGMS, all the people who have worked on these projects, faculty, trainees, staff, the Chittenden Clinic, which is where we did the work, and then also my data safety and monitoring board for both of the trials, who were always supportive. And then last, I'll just put in a plug for some training opportunities that we have available at VCBH. Steve, Diann, Gaalema, and myself are recruiting for postdocs and or predocs. And if you're interested in hearing more about those opportunities, please send me an email. Thank you.
Thanks, Sarah. That was great. So a reminder, if you're here in person, maybe jot down any questions that you may want to ask Sarah about at the end of this session, whenever we go into a panel discussion. And if you're joining us online, you can go ahead and enter those into the question and answer box, right, Charlie? Okay. And we'll move on to our next presenter, who is Kate Hirchak. So Dr. Hirchak is an assistant professor of medical education and clinical science at Washington State University. Her research interest, activities, and training include health policy, assessing alcohol and substance use disorder interventions among American Indian and Alaska Native communities, and culturally adapting evidence-based interventions. And today she's going to be sharing with us her recent work to translate evidence for the uptake of culturally tailored contingency management in partnership with American Indian and Alaska Native communities. Welcome. Yep.
Okay, wonderful. So good morning, everyone. I am super excited to be here. Thank you for the introduction. I'm Kate Hirchak, and I'm an assistant professor at Washington State University. Really excited to be talking about our work, culturally adapting contingency management with American Indian and Alaska Native communities, and then partnering with new tribal communities, implementing CM across the U.S. So I am very much into team science and always like to start out with my acknowledgements here. So the tribal partners that we work with, we could not do this work without them. the awesome team at WSU. So Dr. Michael McDonald, and you'll be hearing from him later in the conference. You might know John Roll. Dr. Roll is also a part of our team, as well as a new partnership with Kaufman and Associates and the Pacific Southwest ATTC UCLA team, Dr. Thomas Fries, my funders as always. And then I'd also like to acknowledge that we are on the land of the Abenaki tribal communities, and just so magnificent, the land here. And I actually have my room looks out over the lake, and it's just such a spectacular view. So really excited to be here. Sure. So I want to start out by talking about alcohol use and misuse in Native communities and pushing back on some of the stereotypes around alcohol misuse being higher among tribal communities. Alcohol use does vary by region and community, but in terms of actual use, Native communities have some of the highest abstinence alcohol rates compared to other racial and ethnic groups. So I think it's really important to highlight that whenever talking about alcohol use with tribal communities. Unfortunately, the health disparities related to alcohol misuse do negatively and disproportionately impact Native communities. And so there's higher rates of cancers and cirrhosis and other alcohol-related negative impacts. So there is a real need for culturally appropriate treatments for Native communities that are culturally responsive and meet the need and the interest and support self-determination and tribal sovereignty. And one such intervention is contingency management. And so I wanted to talk about the Helping Our Native Ongoing Recovery study, which was led by Dr. Michael McDonald. And it's one of 2 randomized clinical trials that was completed with Native communities. So I'll just be talking about the one before sort of discussing some of our work with new tribal partners. So the goal of the honor study was to look at whether using CM led to reductions in alcohol use and how we might culturally adapt CM within 3 partnering communities. So we partnered with a rural reservation community, Alaska Native Healthcare Center, and a city in the inland Northwest, a couple of organizations out of there. So we took a really community engaged approach, had community consultations. Alcohol was identified as the substance that communities wanted to address. We talked about different interventions, and resoundingly contingency management was said to fit or believed to fit with community value around being strength-based and focusing on resiliency. So the honor study was 12 weeks. Participant relatives came in twice a week, and those in the CM group received incentives for alcohol negative urine samples, whereas folks in the control group received incentives for attending study visits and providing urine samples, but regardless of urine, the outcome of the urine sample. We used generalized estimating equations and single logistic generalized linear mixed effects models to look at the primary outcome of alcohol use, as well as some secondary substance use. And the eligibility was self-identifying as American Indian Alaska Native 18 years or older, meeting the definition of alcohol dependence based upon the DSM-4, and then alcohol use greater than substance use in the last 90 days. So here we have the table of characteristics for the participant relatives. The mean age was about 42 with 11.1 standard deviation, and this was similar in the control group. Half the sample was female, and over 80% of the sample had a high school education or higher. So looking at our first outcome of alcohol use here, this graph illustrates, as we all discussed earlier, this induction period. So the first 4 weeks before randomization, participant relatives came in and provided urine samples and received incentives. 158 adults were randomized at about week 4 or 5. And so this is where we begin to see the CM group represented in the orange dots, returning a higher percentage of alcohol negative urine samples compared to the control group. And at the last study visit, the participant relatives in the CM group were about 60% likely to provide a alcohol abstinent urine sample compared to 38% in the control group, and averaged across time, 70% of the participant relatives in the CM group were more likely to submit an alcohol negative urine sample compared to the control group. So this also gets to one of the questions from earlier. We looked at secondary use, and cannabis use was one of the higher used substances in the sample. And so again, we switch from weeks in the study to study visits. And the red line is the CM group. And the dotted line is, again, that induction period. So we're seeing that folks in the CM group are submitting a higher percentage of cannabis negative urine samples compared to folks in the control group. That by the last study visit, that's about 75% in the CM group versus about 55% in the control group. And that during the intervention period, so about week or about visit 14 through 32, after running the fancy statistical models, we saw that participant relatives in the CM group were had 4 times higher odds of submitting a cannabis abstinent urine sample compared to participant relatives in the control group, and that actually by the last visit, the odds were 5 times as high compared to the control group. So basically, we're just really excited to see that contingency management is an effective treatment for Native communities. And it's always just exciting, as we've been hearing, to have this evidence and share it with communities so quickly after publishing the outcome study. So that was published within the last year or two. And it's just very exciting to see that Native communities are leading health and demonstrating recovery outcomes for other folks to learn from as well. So during the study, the honor study, in year 4, we took some time to discuss sort of our process and our partnership. And so the partnering communities came together and we completed this community-based participatory research activity, the River of Life Partnership Story that was developed by Dr. Nina Wallerstein and her team. And so up at the top, you can see the formation of the partnership. So that's year 0, where we were kind of talking about, that community engaged approach. We had a very active community advisory board, which was awesome. And so after, those discussions and sort of that trust building, a grant was submitted, which became the honor project. And you can see as we're kind of moving down the river here, the program development phase, and then we see these boulders or these rocks that are representing some of the implementation barriers that we encountered, and that caused some of the original sites to need to withdraw from the study. And so, now we're traveling down the river and we're kind of at this post-study period, disseminating results and partnering with new communities. So we're taking what we've learned, and over the last 18 months or so, interest in CM training has really expanded, both in Native and non-Native communities. And so our team at WSU and Dr. McDonnell have worked towards creating different implementation tools, so a training manual and a tracker for all those incentives and other things that we can help share with other communities. And so we were thinking about how might we not only align contingency management itself to better fit with Native communities, but how can we do that with our training materials as well. So 4 of the members of the research team, in consultation with some of our original partners, thought about ways to align those materials. And we looked at the literature and other training community, other things that have been tailored to Native communities in terms of training materials. And we were connected with Kaufman and Associates at that time as well. And so Kaufman and Associates are well known in Native community. For many decades, they've supported public health efforts, economic development, and have also provided TA to Native communities on various health-related factors. And then we also partnered with UCLA at this time too, who, as you all know, have many decades of experience in providing technical training and assistance to folks. And so from there, we've partnered with new communities, and this talk is very high level. We have a lot of data sharing agreements and other confidentiality considerations. And so we're just providing a big picture sort of overview of this work. So here are some examples of the way that we not only culturally aligned the CM intervention itself, but also the training materials. And so we have here the medicine wheel, which is a figure to represent health and well-being and balance. And it was originally identified by a couple of our community partners as a way to really emphasize that harmony and balance, the mind-body connection, and the emotional, mental, physical, and spiritual aspects of the participant relative coming in. And so we mapped this onto the CM visit onto this medicine wheel as a way to help folks that are describing CM to participant relatives coming in, or to their coworkers, or even as a way to think about the CM visit themselves. And so always starting at greet, and then just thinking about the next 10 or 15-minute visit of CM on this medicine wheel. And the medicine wheel is also really something that's very meaningful to me as well as a descendant of the Eastern Shoshone tribe. And so this was something that we share with people. But what we really love about CM is that, yes, there are key ingredients that make it work, but it's also something that can be adapted. So this may not resonate with other communities. And so they might develop other approaches or ways of thinking about the CM visit. So we really work with folks on that. So another aspect, not only sort of this concept of recovery and always just being very welcoming and really emphasizing the gratitude towards the participant relative coming in, but the importance of family was another thing that's been highlighted. So not only with incentives being provided where they might be used to purchase items for children, or to have a family night, or to have some sort of other activity that helps repair relationships, but also how we might think about bringing family in during the CM program itself. So we've had conversations around that, and that was one of the training materials that we kind of highlight in our manual, as well as some of our trainings. Speaking in the native language was another thing that was really important. So CM has been identified as a program in tribal communities where you can, create that space to connect with culture or reconnect with culture. So if the person leading the CM intervention can speak their native language, or you have positive affirmations around the office, or just creating that welcoming space, as one way that we really encourage that. Sharing worldviews and teachings when appropriate. There's different levels of where that might fit or might not fit, but certainly thinking that through as you're developing your CM program is one of the things that we've really encouraged. Another thing that really excites us about CM is that any skilled helper can assist in delivering CM. It doesn't have to be somebody with tons of certifications or degrees. And so that creates a real great way for communities to, have different people deliver CM. So elders have led the program, and that's been really successful, and other peer recovery support folks. So thinking that through too. And then recognizing and honoring, again, with this gratitude at the center of the participant relative coming in. So whether that be developing a certificate or having some sort of feast or community event where you're recognizing the person's efforts. The study was called the Honor Study for that reason, because we really wanted to provide that space for folks. And, other ideas have been around singing honor songs or developing honor songs. So there's just a lot of opportunity there to kind of think that through. Another way that we adapted our training materials for Native communities is through storytelling. And this is a really meaningful, important approach in many communities. And so we developed a story about Lance to kind of think about how we might engage a participant relative in the community, how we might sort of frame those recruitment efforts. We also developed some infographics and trying to create more of an engaging visual representation of some of these sort of common conversations you might have in CM around, what escalation, reset, recovery looks like, what not getting a reward might look like, and how you might have those discussions too, because as it was mentioned earlier, that can be kind of a disappointing conversation to have with folks. So here is just a quick high-level look at some of the training and implementation of this work in new clinical tribal settings. And we have the number of activities and then type of activity. And we've had over the last year or so 25 planning meetings weekly with Dr. Freese, meeting with him on Zoom, and the KI folks as well, to kind of think through these new partnerships and how we might support them moving forward. We've had different check-ins with leadership. So over 15 of those have just been about meeting with admin and other leaders who might be interested in CM, or how they might think about implementing it in their setting. And then we've had over 10 meet and greets, and this is the more formal sort of kickoff where we're doing a lot of that relationship building, a lot of that sort of sharing of what we hope to see and envision for this project or program in their community. And then we've had 10 overview trainings, which is just more of the big picture overview of what CM might look like in their community. And then 5 nuts and bolts trainings, which is more specific. So if you're going to start your CM intervention on Monday, the nuts and bolts would set you up for that. And then we've had almost 15 practice facilitator meetings. So this is sort of coaching and, discussing success and how we strengthen that and address potential barriers that are being faced. So I just wanted to close by saying again that CM is culturally responsive. And again, what we really love about it is that it's an intervention that can be adapted. And, if Native communities feel like it's something that they're interested in, it can be effective for them. And because it's strength-based, that's something that they find very encouraging as well. And it's just really exciting to be here where so much of the research has been started and so seminal in this work. And so, again, very honored to be here presenting. Another factor that we encountered was thinking about building capacity and how important that is in delivering CM. With our partners, we have been able to enhance not only research infrastructure, so people have been able to go for additional funding and grants, but also sustaining the current CM program that they have. And so that there's that long-term sustainability there. So really important to think some of that through. Lower buy-in from organizations and community leaders was one of the factors related to some of those rocks in the river that we saw earlier. And so really ahead of time thinking about who's the champion of this intervention in the community, at the administrative level, at the program organization, clinical level, and then externally too, whether that be tribal leaders or elders or others in the community that can really help us with recruitment and sustainment. And then the last thing again is just continuing to provide that TA. So we've been doing that, not only continuing our work with our original partners, but also with the new community partners that we have now. And thinking about that creatively has been something that we continue to work on and are excited to think about more. So thank you for your attention, and please email me or come chat with me if you have any questions.
Thanks, Kate. That was really great. So a reminder again, go ahead and jot down any questions or observations that you want us to circle back to for Dr. Hirchak at the end of the session, as well as entering them into the Q&A box online. And so we'll move now to our third and final, last but not least, presenter. Diann Gaalema is an associate professor in our UVM departments of psychiatry and psychology. Her current research interests include health-related behavior change, as well as the use of tobacco in vulnerable populations, such as those, and especially with those with co-occurring medical conditions. And so as our final presentation, Dr. Gaalema will be sharing her research using CM for secondary prevention in cardiac rehab patients. Diann.
All right. Thank you. So as Dr. Sigmund mentioned, I'll be talking about contingency management in the context of secondary prevention. So talking specifically about a series of trials that we've been conducting in cardiac rehabilitation. So just to remind you what secondary prevention is. So this is treatments or therapies that are aimed to reduce the impact of a disease or an injury that has already occurred. So we have lots of good therapies for established disease, and really a lot of the problems lie in adherence or uptake to those established therapies. So how do we improve adherence and uptake? Well, as you might guess, because you're here, some of our good working strategies involve contingency management. So contingency management, of course, we're trying to promote these target behaviors by reinforcing objectively verified evidence of those behaviors. And we know that the use of contingency management is really good for increasing adherence to health-related behaviors. So there's a large evidence base for that. So when we look in secondary prevention specifically, this is by no means an exhaustive list, but there is quite a literature on using contingency management, or as it's more often known, when it's used medically, as the use of incentives or patient-facing incentives. There's actually a decent literature of this approach within secondary prevention. So, for example, there's been a lot of looking at its use in medication adherence. So, you heard Dr. Silverman talk earlier about ART, and then also approaches looking at improving adherence to other medications, such as those for hypertension, anticoagulation, other medications like that. And we also see approaches to try and reduce other types of risk factors in people with established disease, so trying to get reductions in cholesterol, for example. Or improving other risk factors. So specifically those with cardiovascular disease, there's been attempts to improve, for example, physical activity. So if you can increase physical activity in those with existing cardiovascular disease, that is a great method of secondary prevention. And one of the actually larger parts of literature within secondary prevention and the use of incentives is actually in diabetes management. And as I said, this is not an exhaustive list. This is just an example of some of the studies that have done in there. But I wanted to mention diabetes specifically because that's another place where we see people doing cost effectiveness analyses. So like I said, Dr. Silverman showed us earlier the cost effectiveness for HIV treatment adherence. But there's been work in diabetes as well, and specifically looking at using incentives to improve diabetes management through improved glucose checking, for example, with a goal of reducing HbA1c. And so this particular cost effectiveness analysis was looking at the incremental cost effectiveness ratio of using incentives to improve diabetes management, and found that people that were in the higher frequency incentive groups were decreasing their HbA1cs by 1.7%. And then if you look at that as a cost effectiveness ratio, it's about $1,100 per 1% decrease. And this is actually on the lower end of the cost effectiveness ratio of existing diabetes interventions, where it's ranging from 1,000 to 4,000. So not only do we have examples of incentives being used successfully for secondary prevention, but a growing literature around the cost effectiveness of it. Because as we know, we always get complaints about how much incentives cost to do. And so we feel like we have to push back and say, no, really, we're saving people money, we promise. But I came here specifically to talk to you about cardiac rehabilitation, so I will move into that. So for those of you that don't know, cardiac rehab, it's a medically supervised, structured secondary prevention program. So this is used to improve cardiovascular health in those that have had some sort of cardiac event. So if, for example, people had had a myocardial infarction or bypass surgery or any type of heart valve surgery and some types of chronic heart failure. So patients attend an outpatient rehabilitation program, and programs generally have patients attend 1 to 3 visits per week over a period of 4 to 6 months. And most insurance covers up to 36 sessions of this rehabilitation. What rehabilitation looks like here, it has a big emphasis on structured progressive exercise. The goal is really to rebuild the cardiorespiratory fitness, because that has really good predictive power for improving or reductions in morbidity and mortality long-term. And this is combined with educational classes or one-on-one counseling on risk factor management around other common risk factors, such as diet, physical activity, stress management, and smoking cessation. Cardiac rehab is a really effective secondary prevention program. We know that attending cardiac rehab reduces both morbidity and mortality rates significantly. So you can see about a 1/4 decrease in cardiac mortality over a 3-year period, almost a 1/3 reduction in cardiac rehospitalizations over a 12-month period. And some studies have even looked at the longer term outcomes and see that the evidence suggests that just attending this program for this 4 to 6 month period has benefits even 5, 10 years down the line. But unfortunately, with many of our secondary prevention therapies that are so effective, our use of this therapy is not particularly ideal. It's estimated that less than half of folks that are eligible for this program in the US and Canada actually attend cardiac rehab at all. And then we know that dropout is also a problem. This is 36 sessions of outpatient rehab. It's burdensome. And so not everybody finishes the program. But this is also a problem because the data suggests that the benefits of cardiac rehab are dose dependent. Really, the more sessions that someone attends, the better that their outcomes are. So when we've been looking at cardiac rehab, we've also been looking specifically in our vulnerable populations, and the group that we focused on for our studies is looking at those who are insured through Medicaid. And as part of our, as you can tell from our larger research group, we really have this emphasis on our vulnerable populations, the underserved research groups. And so I just need to mention the disparities that we see in the realm of cardiovascular disease by socioeconomic status. We see both disparities in the development of cardiovascular disease. So our lower SES patients have higher risk cardiac profiles. So they tend to have higher rates of smoking, diabetes, other comorbidities, lower levels of physical activity. And then they also have disparities in their outcomes. They have worse prognosis following their cardiac event. For example, one study estimated the 1-year mortality rate for a lower SES patient was more than double of that of a higher SES patient. So not only do we have these higher risk patients, but then what do we see when we look about how they're using cardiac rehab and secondary prevention? So there's a lot of data out there about SES and attendance in cardiac rehab. So I'm just going to touch on two studies. Some of the best early data was a series of studies done by Soya et al., where they looked at all the Medicare data and looked at all the Medicare data. So anybody was 65 plus, and did they attend cardiac rehab? And in that group, only 18% of them went to cardiac rehab at all. But if you looked at the people that were dual eligible, the ones that were Medicare and Medicaid, or low SES folks, only 3 to 5% of them were attending cardiac rehab. So this was just a drastic difference in participation by Medicaid insurance. So before we started this series of studies, we decided to look locally and see if we were seeing a similar pattern in our clinic, before we got started. And so we did a chart review over an 18-month period looking at participation and completion, and found that our Medicaid patients were about half as likely to attend cardiac rehab as those insured through other insurances. And even more striking, there was a 4-fold difference in the number of people that were actually completing cardiac rehab. So not only were the Medicaid patients not attending, but the ones that were attending were dropping out at much higher rates. So what we have here is a population that really has a high risk cardiac profile. They have historically low attendance in secondary prevention. And so this really seems to be a prime place for an intervention and contingency management in specific, because we know that contingency management interventions really work well for other vulnerable populations. We have decades of research showing that that's true. And we also know that CM is really effective, particularly at promoting attendance of things, really good at attendance, can double completion rates of treatment attendance. And so our goal was to look at how contingency management worked for cardiac rehab, specifically in these lower SES patients. So that was the initial trial that we conducted. We're looking specifically just at the use of CM to improve cardiac rehab. A little bit about our method. So for this study, we recruited 130 Medicaid enrolled patients who were eligible for cardiac rehab. So our inclusion criteria were pretty broad. They just need to have one of those qualifying diagnoses and be insured through Medicaid and living in our catchment area. We excluded very few people. It was generally if people were receiving end of life care or couldn't ambulate. Those are the main reasons that someone wouldn't go to cardiac rehab. And everybody in the study was enrolled in our usual cardiac rehab program, which is those 36 progressive exercise sessions and the associated information. And those 130 people were randomized either to earn incentives or into a usual care. In our incentive condition, the incentives were contingent upon completing those cardiac rehab sessions. So someone had to come, they had to complete all the activities that the clinical staff wanted them to do that day. And if they did that, then they earned incentives. So the incentives generally were on an escalating scale, so starting about $4 and going up to $50 per session. And we had a reset in there, contingency in there, because we know that the escalating resetting contingency is really effective for maintaining long bouts of behavior. To look at the participants from this initial trial, they really were representative of what we would consider a high-risk population. Some things that really stood out to us, for example, is they're very young. So the average age of this group was 57, which may not sound terribly young, but if you're in a cardiac rehab program, that's young. It's about 10 years younger than the average cardiac rehab patient. 42% of them were currently smoking at the time of their qualifying event. That's high. And this is Vermont, so this is really high. They had fitness levels. This is cardiorespiratory fitness measured through gas exchange, so peak VO2. They had fitness levels that are reflective of someone 10 years older than them. And they had really high levels of psychosocial comorbidities. So we had elevated depressive and anxious symptomology in about 60% of them. And surprisingly, we also had 40% that were self-reporting executive function challenges that were at concerning levels. Primary outcomes from that initial trial. So participants that were in that incentive condition earned on average about $700. They completed significantly more cardiac rehab sessions than our usual care, and they were almost twice as likely to complete the entire 36-session program. One of the things that we were interested in looking at in that initial trial was hospitalization usage. As I said, this is a high-risk group, so we assumed going in that they would have a lot of use of the hospital system. It wouldn't surprise us. So in this initial sample, yes, most participants entered the hospital system at least once in that year following their first event. So they either entered the ED or they were hospitalized overnight. And some of them had 10 or more within that year. So a lot of usage. One of the interesting things we noted, though, is that not all of these hospitalizations or ED visits were cardiac related. About half the hospitalizations were, but only maybe less than a third of the ED visits. So there's a lot more going on in this population than just their cardiovascular health. And this is just really reflective of the high level of comorbidities in this population. So those visits could have been anything from injuries to pain, COPD exacerbations, all sorts of things. Just it shows us just kind of what a sick group this is. I don't think any of us really realized how much sicker the Medicaid population was until we went through and looked at some of this data. So one of the interesting things that we found from looking at these results is that those people that were in the incentive group went to the ED visit for cardiac related things much less often. So this is not particularly surprising to me because they're going into cardiac rehab, they're talking with the staff, they're getting education about their cardiac related stuff. So one of the things the staff does is they teach them what's something I should be worried about and I should go to the ED about, and what's something that's okay and I can manage. So it would make sense that people that were getting incentives for coming in and attending cardiac rehab would be less likely to show up in the ED for these chest pain related incidences. But we didn't see any sort of signal in all of the rest of those different types of disorders that people came in for. So based on this initial trial, our thought here is, what can we do better to serve this population? How can we further improve and support attendance? And how can we support these patients with this high comorbidity load? There's a lot going on here that's not cardiac related. And then in addition, those psychosocial and cognitive issues that we're seeing as well. How can we support these patients with the anxiety and the depression and the EF challenges? So what we did is took a page from the Higgins cocaine trials and adapted the community reinforcement approach for use in our cardiac population. So the idea behind the community reinforcement approach is you're really trying to help a person shape their environment so that it is more supportive of their health-related goals. So when you're doing with substance use, you try and shape the environment so that it provides more reinforcement for non-substance use related activities. So from a secondary prevention perspective, it's more like you're trying to help shape the environment so that it's more supportive of their secondary prevention behaviors and goals. And the reason that we wanted to look at CRA, which I'll call case management for the rest of it, because that's a more acceptable term in the medical community, one they recognize anyways, is that we know from these CM-CRA studies that adding CRA on top of CM has a lot of additional benefits. For one, it improves attendance further than using incentives alone, but it also improves outcomes beyond attendance. So that the cocaine trials show that not only did they have improved retention, but there were also better outcomes on hospitalizations and on depressive symptoms. So this seemed like a good place to go with this. And one of the things that also made it seem like a good place for us to go with these patients specifically is that case management is an accepted practice for someone who's been hospitalized. It's a known thing in the medical field that, you can give someone a case manager when they're in hospital to improve outcomes. But it's not well implemented in the US, so there's still a lot of room to work in that area. All right, so that brings me to the current trial, which is it's ongoing, and what we're looking at is the use of contingency management and case management to try and improve cardiac rehab participation and secondary prevention outcomes in these lower SES patients. So for this study, we're recruiting 209 lower SES patients that are eligible for cardiac rehab. We're at 199, we're almost done by the end of the year. Very excited. And the inclusion criteria are the same as they were for the prior study. They just need to have a qualifying diagnosis and be insured through Medicaid. So one thing I wanted to point out is that these participants look very similar to that from our first study. Once again, they're very young, high rates of current smoking, low levels of fitness. So it's the same group we had last time. And in this study, what we're doing is we're randomizing them into one of 4 conditions. So either they will receive usual care, they receive incentives for attending their cardiac rehab visits, they receive a case manager in hospital to support their attendance, or they receive both interventions together. The incentive schedule for this trial is very similar to that of the first trial, escalating with a reset. So what does our case management, our community reinforcement approach look like in this trial? So what happens is that in hospital, the participant is assigned a case manager who meets briefly with them while they're in hospital if possible. But once that person's discharged, the case manager does an initial needs assessment with that patient. And we took a page from the cocaine trials and really made this a broad needs assessment. We didn't really go in with any preconceived, this is what's going to be interfering with your secondary prevention. So the needs assessment asks about all sorts of things that could just be, disrupting your life. What's keeping you from being able to focus on your recovery? And so some of this is, do you have medical needs? Some of it's, do you have social needs? Do you have psychological needs? Are there practical needs? Just really kind of dialing into what is keeping that person from being able to take care of themselves. So the case managers do that initial needs assessment, and then they have weekly calls with the patients to set goals about what can they do to improve their cardiac health, help them overcome any barriers to those goals that they find, and just serve as, cheerleader encouragement, for these folks. And the case managers are also available to answer any acute needs that the patients have. If they have a question that they want someone to give them an answer to quickly, they're available for that as well. All right, so I'm just going to share some interim observations. Like I said, we're not done, so this is all preliminary, but it's fun to talk about what we've seen so far. All right, as I said, this is still ongoing, so take these with a grain of salt, but the last time we did an interim analysis, we took a peek at our completion rate. So this is the number of people that actually completed all 36 sessions. And what we see is it's in that graded manner that we would expect. Our usual care is doing terribly, unfortunately, and our single interventions are doing pretty good, and the combination of the intervention seems to do the best. One thing I'll point out is that the difference between our two conditions that are same as the last one, the absolute percentage point is the same. It's 25 percentage points difference. The biggest difference is that everyone's doing so much worse than they were in the last study. If you remember the usual care, about 25% of them completed the whole thing. Now we're down to 5%. It's almost like something really bad has happened over the last couple of years. It's causing people to struggle. But the absolute percentage is the same. So I'll just make a couple notes about how people have been using the interventions. We've been distributing our incentives in the form of gift cards or checks to businesses for this round. And this kind of helps us, we frame this as people can earn these incentives and then use those incentives to further their health related goals. So we encourage them to use this for things to get over barriers that are keeping them from engaging in secondary prevention. A lot of this is gas, so transportation. We're a rural state. It takes, some people drive 45 minutes to get to the clinic. It's a long ways. And a lot of people buy healthy food. Some people need to buy sneakers. We have several folks that all they have is their steel-toed work boots, and our clinicians don't like those on the treadmills for some reason. But we don't require it. And that's just what we see, that we do see that people are using these for a variety of things, and often specifically for ways to overcome some of those barriers that they have. The case management arm has actually been really interesting to us as well. So one thing that I will note is that our case managers get used, and they get used a lot. We weren't sure if anyone, how many people were going to want someone that was randomly assigned case management or not. They didn't get to choose whether they got case management, but most people use our case managers if they've been assigned one. So if you look at the percent of weekly calls that are completed, about 80% of them are completed. This is completion even by people that don't go to cardiac rehab. They may not go to cardiac rehab, but they still call our case managers and do their check-ins and work with them outside of cardiac rehab. And as I said, we went into this with not really trying to figure out what people were going to need in advance. And so the things that people are asking for help with are actually very diverse, and they're not always medical or even financial in nature. I'll say that one that was a surprise is that we had a need here for childcare. Usually we don't think about people in cardiac rehab needing support with childcare, but when you're looking at our Medicaid population, we have like ladies that are 42 years old and they have young kids. They can't come because they've got young kids. So it's a need. So commonly addressed issues that we've run into so far, people like help with communicating with the clinical staff and arranging medical transportation, organizing and understanding their medications, getting assistance with food, managing their symptoms. But the most common thing that people have been reporting that the case managers have been reporting offering support with is psychosocial support. So we are seeing really high rates of anxiety and depression in this population. And we see this in that the patients are really scared to do anything. They've had an event, they don't want to do anything, to have another event, they don't know what they can do. And they're really kind of overwhelmed about all the things that they have to do to try and take care of themselves. And one of the other things that really stood out is we're seeing a lot of social isolation. We have patients that will say to our case managers, like, you're the only one that ever checks in on me. And so there's a lot of psychosocial needs in this population as well. All right, so just to summarize, our lower SES patients are really at high risk of negative outcomes following these cardiac events. They have a high disease burden, they have high rates of comorbidities, lots of psychosocial issues, and historically have had lower rates of attendance at secondary prevention. And so what we've seen here is that contingency management is really successful at improving attendance at the secondary prevention program. But we also see that given the complex needs and the psychosocial issues that is going on in this population, that there's probably you need to add something on top of contingency management to really get those optimal outcomes. All right, and I was also asked as part of this presentation just to think about how better we could implement contingency management in this context. And I really think that cardiac rehab is one that would lend itself well to implementation. the behavior that I'm reinforcing is one that is already recorded in the electronic medical health record. So you already have evidence that it's happening, and you could just check that, and you could deliver incentives remotely, and it actually lends itself pretty well to that kind of implementation. And I think that really just what might have to be considered is how we would balance rigor versus ease of implementation as far as the kind of reinforcement schedules that we usually implement. You know, doing things like resets and escalating schedules would be more difficult under those kind of situations, but a flat non-resetting incentive schedule could be easily implemented. All right, so I just wanted to end by thanking my collaborators. So this is our clinical and research staff together. I love collaborating with the clinical folks. It's a lot of fun. And if anyone has any questions, feel free to email me later or ask questions as we're up here. And if you missed Sarah's plug, I'll just remind you, trainees who find this kind of stuff interesting, pre-docs, post-doc slots, email Sarah.
Excellent. All right. Well, I'll now ask all three of our presenters to come back up and join us. We've covered a lot of ground. I was thinking wide range of target behaviors and populations and settings. So hopefully there's some questions for discussion. Maybe we will start with our in-person attendees. For anyone who has a question or comment, feel free to come to the microphones, and then we can intersperse, Charlie, if we have some questions as well coming in online.
Thank you, everyone. I have a kind of a generic question, so it's addressed to anyone fairly new to understanding the contingency management literature. Does contingency management work also for higher socioeconomic populations? I know a lot of the discussion today, rightfully so, is focused on people in poverty, but I'm wondering, someone with an average household income, does the incentive amount need to increase substantially to be? So if you could just speak to that, I'd love to hear about it. Thank you. Should we talk about that?
I don't know if I know the answer.
I can give you some answer. As far as I can tell, there is no evidence that it works less for a low SES population than a high SES population. And I know some people actually argued that incentives might work better for higher SES populations because people are more sensitive to monetary rewards at higher incomes. I mean, we definitely do focus on low SES populations because that's where the greatest need is, but I haven't seen any evidence that it doesn't work in the higher SES populations just as well.
Yes.
Hi, thank you so much for all of your work. I just want to thank you for that. And I was wondering if the panel could speak to any efforts to train the workforce to carry out the programming. A lot of the implementation work that we do, a lot of times we hear, I think, some of the stigma behind this work. Why should we pay people to do the things that they should be doing and that sort of thing? And I'm wondering if you could speak to any of that. Thanks.
Yeah, so I can definitely start us out here. So on my little graph, you saw the practice facilitator sessions, and even before that, we just have really open conversations around, what are your feelings about CM, and do you think this is something that would work in your setting? And so it's something that we really try to discuss head on and really validate folks' concerns while also presenting the evidence to them. And so that's something that we've definitely worked on a lot. It hasn't actually been my experience that we've gotten too much resistance around that. I feel like people are really interested in, being able to provide this to their, patient population. So, that's, you do hear the concern around if the incentives might be misused or something like that. But in terms of actually providing it, we haven't had too many challenges with that specifically.
I can say we do get a feedback about, why should you have to pay someone to do something they should do anyways? And I think often it just needs to be a conversation with someone about what the goal of this actually is. It's not to pay people to do things. I like to talk about it as, it's a motivational tool. It's a way to really keep people engaged and focus on what they need to do. And just give the example of, when you're for my cardiac populations, right? When you're recovering from an event and you have all this other crap that's going on in your life, in our low SES population, right? They got their house getting foreclosed on or something, their kids in jail, what's going on? It's like, this is a way to help people bring focus to being able to take care of themselves. And sometimes when you can reframe it as what you're trying to achieve and not just kind of the simplistic, we're paying you to do this thing, then you can convince some people in that way.
I was just going to add, I've specific to, I think, sexual and reproductive health, I've run into more the issue of it being coercive and having to address. That's why I emphasize so much in my methods that this is about attendance and it's not about using contraception. So I just think that that's an area where we have to be extra careful in a way that we maybe don't always think about, of making it really clear. And we haven't done anything in terms of trying to train anybody else how to do this. We've still kept it pretty much in the ivory tower, but that is something that I anticipate we'd have to be extra careful about in the future.
In a way, I will say, speaking to the training side of it, I mean, there are efforts ongoing to improve training and dissemination. I'm just looking at Rick over there. Just ask Rick. Rick's got it all under control. But I know that there's, for example, there's a contingency management training video that's over at the Cora table out there if you want to check it out. So there are ongoing efforts to improve implementation. But yeah, I would suggest looking Rick up.
Yes, please.
Yeah, and the issue of cost effectiveness for family planning, did you consider the impact and the cost of mandatory reporting CPS associated with women who are pregnant or intend to get pregnant, and explaining to them what their rights are? There are some jurisdictions that have mandatory reporting, even if you're on methadone for treatment.
Sure. Yeah.
And then what about the impact of methadone and pills, estradiol? There's at least one study that shows that methadone, that estradiol decreases your methadone levels. Therefore, people start going through withdrawal.
We did include in the cost benefit analysis some costs related to CPS, and it's not an easy thing to get data on. So I won't claim that it is the end all be all, but we did try to incorporate that into our estimate. And I was not aware. That's very interesting about the estrogen and the methadone. I can't say that we had we collected information about adverse events, and we have actually analyzed those data. And obviously withdrawal was a not uncommon complaint, but I don't know, we would be able to look at it because a number of the methods that we offer were progesterone only, whereas pills and patch and ring are can be combined. So we could split it out by method and look at whether those who are on combined hormonal contraceptives had more reports of withdrawal than others. I'm not sure, what the levels have to be to have that effect, but that's really interesting. Thanks for mentioning that.
Sarah, were the women, did you stratify in randomization of whether they were on high or low methadone or buprenorphine doses? Or were they pretty simple? Would there be anything interesting to look at it by dose?
Yeah, we did not stratify on dose. And yeah,
Because that would be withdrawal as well, possibly, or,
right. I'm honestly not sure that we even have dose in the data, but, and also it could have been buprenorphine too. But yeah, I'll definitely look into that.
Sarah, my question's for you as well. I was thinking about the recent Supreme Court overturning Roe versus Wade, and I can only imagine that the demand for contraceptive services is going to increase And I think, has all your work been in person?
Yes.
Have you thought about trying to do it remotely? And I'm particularly interested maybe in your thoughts about the political challenges of that kind of approach. It just seems like there's going to be such a need and it's so effective, but I can imagine it's going to be really challenging.
Yeah, agreed. I haven't thought about doing it remotely. One of the real benefits of it is the being in person and on site. Like we're literally upstairs from the treatment clinic. So, presumably they're already going there on a pretty regular basis to get their dose. And they just have to come upstairs to see us. And this wasn't true in the initial trial, but in the fully randomized trial, we could do IUD and implant insertions on site. So literally they could walk in the door, and if that's what they wanted, 5 minutes later, they could have it. We could also do removals just as quickly for anybody who decided that it wasn't for them. So that seems like such an important part of it, that turning it remote, like trying to figure out how you could do.
You could do the motivational part.
Yeah.
In there.
Yeah. Yeah. I think it's definitely worth thinking about, because I agree with you. I think the demand is only going to go up in the foreseeable future.
Yeah. That's a good question. Lauren?
Yeah, thanks very much, everyone, for your presentation. It's really interesting. I have another one for Sarah, sorry. I was wondering if you had any data, I might have missed it, on the length that participants have been using opioids in the sample. And then related to that, whether if there's any data on the level of unintended pregnancies among younger cohorts of women, and then if there would be scope for these kinds of interventions in those populations, maybe before or soon after the onset of opioid use disorder.
I don't think we have information about how long they had been in treatment. And I actually that wasn't a factor, but I actually think that is the best way to do it. Like, I really want this to be something that when they come in to start treatment, this is a conversation that is had, and that this would be an intervention that would be available to them. So trying to, as part of that initial, startup into treatment, this is one of the issues that gets covered. And what was the other part of your question?
It was about the kind of level of unintended pregnancies among younger cohorts of those with opioid use disorder.
Yeah, I also think trying to figure out a way to get this out in some setting for people who aren't in treatment yet. Often by the time you're getting them in treatment, as you saw, like they're already in their 30s, they've already been pregnant 3 times, like a fair amount of the damage is potentially already done. So how could we move this out and find women who are at risk for unintended pregnancy who aren't in treatment or don't want to be in treatment yet, or something like that? Yes, I've thought about that a fair amount and haven't come up with a good answer yet.
There's such an explosion of harm reduction efforts, like distributing Narcan and syringes and fentanyl test strips. Do you think it would be appropriate to consider kind of partnering with with those types of groups that are?
Yeah, potentially. And I mean, again, like IUDs and implants, like that's sort of ideal that you can do it very quickly and it's long lasting. You just have to be really careful that, that then women still have the opportunity to, control that because it also has to be removed by a professional, that there could potentially be backlash that, yes, you're putting it in, but then you're sending them out with no way for them to remove it.
Right. That's a good point. Charlie, an online question?
Yes, we have a question from Donald Shepard for Dr. Gaalema. You mentioned that the reset conditions might need to be changed in future applications. Why, and what would you recommend for the future?
So that was my comment about how you could possibly more easily implement this, like outside of a research setting, is that if you decrease the complexity of the incentive schedule, it would be more easy to implement in a fashion. So that was a suggestion of like, we can see if someone's completed one of these sessions in their electronic health record. It's marked obviously as completed. It's part of the billing system and everything. So you could just see that it happened without interacting with the person at all. But to reduce the burden of not having to have like a research person specifically doing a research study, that having like a flat schedule without resets would be more easy to implement in a non-research setting, but we might lose some of the rigor of the escalating reset schedule that we know and love.
Thanks, everybody. Question for Diann. Diann, I don't know much about cardiac rehab, but building on what Jen said and what you just talked about, are there some of the cardiac rehab activities they can do at home and you can record digitally, or you can, like you said, you can start to verify things digitally, deliver incentives digitally. And it seems like, I assume that decrease in attendance has something to do with COVID and attending at all, right? People are just afraid to go out or whatever. So getting a way to do it at home, I know people don't have treadmills and things, but have you given that some thought? And the second part was, case management and CRA, you kind of put those together, but what differentiates CRA is actually getting out and helping people do something new and really kind of more in-person support. I guess you could do more online, but same targets, but really getting out there. And for example, you said people are afraid to do new things. To have somebody holding their hands while they do them, which would be a traditional CRA thing, might be very valuable.
Yeah, no, I know we lost some of the original CRA with the way that we had to adapt it for use in what we were doing. To go to your first point, so yes, there have been approaches to move more of cardiac rehab home. So hybrid cardiac rehab is a thing now, right? Or even telehealth cardiac rehab is a thing in some places now, with the idea of that. I mean, I think ideally right now, in-person cardiac rehab is really what we like, because there's value in getting a person into the clinic and giving them a real thorough evaluation, doing their stress test, know what they're capable of and their level of severity and all that, and giving them an exercise prescription that's really specific to their particular needs. But there's an argument to be made that once you have that information on that person, and if they're not at any particular high risk of doing this work on their own, that you should be able to support them to do their exercise where they can get it, or get their education online if that's easier. And we have capacity issues with in-person cardiac rehab too. So that's a consideration as well, as if we could, get cardiac rehab out to more people through those hybrid or remote options, then that may benefit a group of people that couldn't be served in person anyways. But we do kind of come back to, like, we really would like to see them at least some in person, just because of those, especially initial meetings. And to talk more about the case management. So one of the things we had to do is we really wanted to be able to make this, that we could do the case management remotely, right, by phone. They do see them in the hospital initially, and then in the clinic if they happen to come by. But we were trying to make it easier to implement on that level by having it be able to be remote. But I do think you really have a good point that there is room in the cardiac rehab world. We see a lot of anxiety, right? And my grad student, he's not here right now, but he was doing some work looking at the effects of anxiety on fitness improvement. And these higher levels of anxiety are keeping people from probably exercising at the levels they need to, which is impairing their ability to improve. And so there's room for actual psychosocial interventions to help with these issues, which would probably improve their outcomes. So yeah, the same idea. Get someone to treat their anxiety so they can engage more fully in the exercise. If you could, walk them out into the environment and figure out the places where they can walk safely, where they can buy their food that they need, walk them through the process of doing these things. I think that, that could definitely have value. But yeah, the thing we have in place is trying to balance kind of the existing case management structure as it's known in the medical field, and being able to implement it fairly remotely.
Diann, I have two follow-up questions. One, like on the thread of some of the exercise being done at home or around. Does your group use kind of the pedometers that are now in all of our devices to objectively monitor how much activity patients are doing outside of when they're not at the cardiac rehab? And could that be something else that could be reinforced? And then two is your case managers, you presented a lot of the needs that they address and things they're asked. Are they actively problem solving with the patients, how to get them back to their next rehab appointment as well? Like kind of a motivational interviewing thing just to get them to stay?
So to your first question, so the interesting thing is when we got shut down by COVID, we did send pedometers to everyone. So we were doing cardiac rehab remotely for those 3 months. So we sent them pedometers and reinforced them for doing steps instead of coming in for exercise sessions. But that is definitely a thing. So that various studies do look at activity levels. And I know my collaborator, Sherry Kadanga, specifically is doing some work with women in cardiac rehab and sends actigraphs with them at home to see if case management is effective for getting them to improve their physical activity level overall. I don't collect actigraph or pedometer data for this particular study. And the other question was,
I was just wondering if the case manager CM.
Oh,
if
yeah,
the
right.
CM, we're doing CM.
so their primary goal is to get the person into cardiac rehab and to stay in cardiac rehab. So that is like the number one goal that they're supposed to address each of those weeks is what's keeping you from going? How do we overcome that?
You're just surprised at the
problem
breadth of
solve.
other things, but that is their main.
Yes, that is their main goal.
Okay.
But there's just some people for which going to cardiac rehab isn't happening for one reason or another. So we also have all right, what are other goals that you can work on to improve your secondary prevention, even if you're not coming into the program?
That's
Comment and a question. First of all, it's very exciting to see these data for the first time. Because when we designed this study, I think we had the impression that case management was not going to be as effective as financial incentives. And a really important thing about case management is we already have it.
Yeah.
We already have nurses running around the hospital and doing discharge planning with our cardiac patients. And it's their job. I could see us taking this information to one of our monthly cardiology faculty meetings and say, look, we have this data and we need to change what our case managers do because look what it does. They're more likely to go to cardiac rehab. My question is, have you yet looked at if it also, the case management, does it also reduce emergency department visits? Does it also reduce hospitalizations, which we have already shown financial incentives does affect?
Yep. So stay tuned for that data, Phil. So we collect ED visit and hospitalization data for the year that people are enrolled in this study. So post-discharge to past the 3 to 4 months that they're enrolled in cardiac rehab, and then the additional 8 months past that. So we have not pulled that data yet as we are still in process, but I am excited to look at the hospitalization utilization because we do have a planned cost effectiveness analysis as part of this study as well.
Because if we show that, how could the cardiology group not do this?
I don't know. How do they keep pushing back against incentives?
Yeah.
that actually undermine the interest in the group to adopt CM.
Yeah.
Like if their current paradigm of case managers is cost effective and effective.
That's just one thing that always is funny to me is that the cost involved in hiring a person to do case management is never discussed as an issue, but the lesser cost of having a research staff implement an incentive intervention is suddenly super costly. So
Yeah.
it's all about optics, apparently.
Absolutely. While we pass the mic around, Kate, I had a question for you about your alcohol, your biochemical testing for alcohol, because we've always done breathalyzers, which, you know, only detects recent. And then I knew there was transdermal and scram bracelets and stuff, but the ethyl gluc test in urine, are you having a good success with that? And how many days?
What's the half-life?
Yeah, what's
Yeah.
the, like,
So 5
detection?
days.
Okay.
Yeah, and so heavy, So heavy use of 5 days and then shorter life of 2 days for.
And did you have to do much piloting with that, like methodological, or is it pretty well established?
So Dr.
use-
McDonald's work actually established that. And then we built upon that with so he had studies with folks with serious mental illness and used that and published around that. And then we were able to build on that with our native work.
I think it's really exciting because I've not been involved in the CM alcohol studies, but I know that was always a barrier in terms of the detections and the time half-life.
About 50,000.
Okay, so that's awesome. Rick.
Yeah, just one comment. I really
appreciated Kate's presentation that you've taken the clinical trial and you're now moving down the river with it and doing some implementation stuff. And to that point, Diann and Sarah, we can't let happen what happened to Ken. I mean, and to the whole CM field where it sat there. Those two are no-brainers that should be in this health system. I mean, it seems like, I think about you're working over at the Chittenden Clinic. They should be doing that. I mean, as a routine clinical practice, we got to figure out a way. Maybe we need to bring Sarah Becker in to show us how to do implementation research to get those things moving, because those are both great studies.
Yeah, agree. Rebuttal, response, comment?
I was gonna say, Rick, I think I just need a kick in the butt and I'll get moving that direction. Just come see me later.
She'll account for this next year, this time when she sends you. Next question.
So I have a question for Kate. Regarding the results where, the alcohol use was down in your intervention group as well as their marijuana use, if I'm interpreting that correctly. Are you surprised by that? And I ask because I know within like the veteran PTSD space, many of that population has some sort of substance use disorder, and there's concern about treating the substance use disorder in the absence of treating like the trauma that they have gone through. Because one might just replace, a coping strategy might take up that space. And given that you're working with groups that have like generational trauma behind them, I guess I'm a little surprised to see those data.
Yeah, that's a really good question. So consistent with other studies, of course, there is this off priority substance reduction. So I guess it didn't surprise me, but we haven't really looked at some of those, questions around trauma or intergenerational trauma and how that might impact that. So I think that would be a really important sort of thing to assess. We don't really have measures to do that totally. We did include one around historical trauma and the impacts of that. But there wasn't really connection with the alcohol use with that measure either. So I think that's something that we definitely would want to continue to look into. And we hear that a lot from communities too, the importance of really addressing trauma, both intergenerational and acute. So definitely want to move in that direction.
Steve?
Just a quick comment to follow up a little bit of Rick's point. I think Rick and I are in the same cohort, have been watching this for a long time and just slap our foreheads. But I wanted to share a thought, and that is there's a lot of evidence actually in medicine that this bias wherein you are much more likely to be criticized or sued for acts of commission compared to acts of omission. That is, you will almost never get sued for medical malpractice because you didn't provide a service, but you get sued regularly when you do. And I think that's probably operative. I won't name names, but I think some people are policymakers are just very loss averse, and they don't want to put CM out there and get criticized that you're paying people to not use or to go to cardiac rehab or whatever. And this omission versus commission is in the literature. It's a real thing. So how do you change it? The only thing I can think of is advocacy, calling out policymakers for acts of omission. But that's an uncomfortable thing to do. The group I would look to is the advocates for proper medication development for HIV. And I actually witnessed some of the acting out against the policymakers who were slow walking the drugs that Ken spoke about this morning. And they got returns, they got results. Dr. Fauci even acknowledges that the advocates changed his behavior. So, get ready to raise heck.
Other questions or observations? Yeah.
comment on the alcohol and marijuana results. Have you used some kind of qualitative techniques to explore them? I wonder, actually just asking people, why did you also stop using marijuana? That could bring to some interesting results.
We have not, but I think that would be something to add since I am doing more qualitative work around some of this now. So that would be really interesting to kind of chat about what some of the factors might be around that, especially since, like I said, the cannabis use is, pretty much used at the same rate as alcohol. So.
I mean,
great
are,
question.
and are they used concurrently? Like whenever we do interventions to reduce illicit opiate use, say heroin use, you can often see co-occurring decreases in cocaine because people are using them, speedballing. And so
I mean, that was going to be my comment as well. I mean, often we're saying that when we treat one substance, use of other substances decreases. I know it's commonly worried about that you treat this substance and then use of this other substance is going to go up. But I don't, someone can correct me if I'm wrong, but I haven't seen evidence of that. It's usually the other direction.
Yeah.
So when I'm not surprised that you're treating alcohol and that marijuana use is going down as a result. So that's me.
Yeah, that's great.
I know it's commonly out there as a concern.
Yeah, especially among clinicians.
Yeah, I just don't think it's not well supported by the data, I don't think.
right. Well, while everyone is thinking about any final questions, I'll go ahead and advance to our last slide here as well, or try to. I just wanted to put in a plug. It's not advancing. Do you want to, or can you do it from there? I wanted to just share with everyone during our upcoming, so this is the last session before our lunch break, which Charlie, I assume is next door, is lunch there. And then during that, there is a session on rural health disparities. And is that, Charlie, back in this room? So we can grab our lunch if we wish and come bring it back in here. And the chair will be Jen Tidy for this lunchtime session. And the presenter will be Megan Roberts from the Ohio State University, discussing rural disparities in tobacco use. And so I definitely welcome everyone to consider bringing your lunch back into here and enjoying that talk as well. Any final closing arguments or questions before we disband? If not, I'd like to give a hand to our presenters again. Those are good. Enjoy lunch, everyone. See you in a bit.